Hello, good evening. Welcome to my IVF Answers, everyone, and welcome to our webinar today. As you can see, Dr. Harry Karpouzis is with us already. Hello, Dr. Harry. Welcome back. It's great to have you. Hope you are all well and are ready to get give us some tips, but also explain the process of IVF step by step. How are you? How have you been?
I'm fine, Caroline. Nice to see you again, and nice to see everybody here. And I'm waiting to explain things about IVF. For a difference, it's an easy topic, but I really like it because it's the baseline things that everybody needs to know about IVF. We usually talk about very complicated things. It will be different now. And I hope we help everybody in the first steps of IVF.
Exactly, that is why we are here. So as you probably seen some of our previous webinars, we usually focus on recurrent miscarriages, etc., with Dr. Harry especially. But today we just wanted to go back and just start to explain from the very beginning. So remember that if something is not clear, some shortcuts or anything like that, please remember to just simply type this in the chat. We will be happy to explain this, and I'm sure Dr. Harry will be happy to help you out. And for those who haven't been able to join us before, I just want to let you know that we will start with Dr. Harry Karpouzis' presentation on our topic, and then we will have your questions. So remember to put those in the chat, and then Dr. Harry will simply answer them for you. So don't hesitate. Anything that's on your minds, anything that you would like to ask a doctor, you can do it. And this is all anonymous as well, which I know is important. So don't worry, all is anonymous and you can type anything right here. And this is also being recorded. So if you will need to leave at any point, remember it's being recorded and you will have a chance to rewatch this. It will be available on our YouTube channel as well as our website, myivfanswers.com. My name is Caroline, I'm your host, and I'm really looking forward to this discussion. And I think we can start with our presentation, right, Dr. Harry?
Yes, sir.
Let's go for it then. Thank you.
Okay, so hello again to everybody. I'm Harry Karpouzis. I'm the scientific director of Pelargos IVF. We are a fertility clinic, fertility group. We are based in Athens, in Greece. We will talk today about IVF with own eggs, and we hope that this will be like a beginner's guide. Let's start from the definition. So what is IVF? IVF means in vitro fertilization. And what actually means, it means that we take the egg, we take the sperms, and we combine them in a lab. We leave them in a lab to get fertilized in special cultures. And then embryos are created, and we take this embryo or these embryos and we transfer them to the uterus. And any embryos that are left, we can freeze them. And the technique that we freeze them is called vitrification. It's the newest technique, and it really doesn't compromise the quality of the embryos nowadays. You have heard maybe about ICSI. What's IVF? What is ICSI? IVF, we take the eggs, we take the sperm, we culture them in lab, and we let them get fertilized there. ICSI, we take the sperm and we inject it directly inside the egg. And why we are doing that? We are doing that so that we can increase the chances of fertilization. It started by using this technique for a male factor, but nowadays we don't always use it for male factor. We use it even when we have a small number of eggs, because we don't want to risk the fertilization. Why someone would do IVF? The most common reasons, blocked tubes. If someone has blocked tubes, cannot get pregnant by herself. Severe male subfertility, when the sperm has really low percentages of motility, of morphology, of quantity. AIDS-related issues. We know that the AIDS affects the quality and affects the number of the eggs as well. Endometriosis, many times the solution is IVF. Unexplained infertility, another very common reason that IVF gives the solution, and persistent PCOS, which is not reacting to ovarian stimulation with Clomid, with letrozole, or previous attempts of IUI have failed. When do we consider a couple subfertile? When the woman is less than 35 and a couple is trying for like more than 1 year to conceive, this is a subfertile couple. After 6 months of unsuccessful trying, when the woman is more than 35, we need to be more proactive there. If we have other treatments that have failed before, so for example, controlled sexual intercourse, follicular tracking, IUI, ovarian stimulation, the next step is always IVF when these treatments have failed, and these treatments have much lower chances of success of IVF. They are less intrusive treatments. We can try them on some occasions, but if they don't work, then the next step is IVF, and IVF always has better chances of success. When we need to do PGTA, which we will talk about it later, and it is chromosome check of the embryo, biopsy of the embryo to check the chromosomes, or when we need to do PGTM, which is when a couple has a genetic disorder, a single gene disorder. When we do PGTA when the woman is more than 40, and we do PGTA when we have recurrent implantation failures, recurrent miscarriages. In unexplained subfertility, many people are doing IUIs in unexplained subfertility, but the truth is that the NICE guidelines for many years now say that it's better to do expectant management, and if this doesn't work, jump straight to IVF. It doesn't give any strong evidence to IUI in unexplained subfertility, and especially in unexplained subfertility with low AMH. Then in cases that we are in a hurry to get someone pregnant, in these cases, we want the best chances of success. And for example, in advanced maternal age or cancer treatments planning before chemotherapies and things like that, we need to go with sometimes preservation of the eggs or IVF, etc. And with the blocked tubes, of course, if both of the tubes are blocked, the only solution is IVF. But many times when only one of the tubes is blocked, if the expectant management doesn't work, IUI is not the right solution. It is better to jump straight to IVF. For those that do not know yet, what is the IVF process? What we are doing? First of all, we create a protocol. We take hormones, and these hormones are similar hormones to LH and FSH, which are hormones that are produced by the brain. Synthetic hormones most of the times, and we stimulate the ovaries. We can do that with hormones, and sometimes we can do it with pills, which is called a semi-natural cycle, and sometimes we can do it on a natural cycle without anything. And then all this leads to the follicles to increase in size, and when the follicles are ready, we do egg retrieval, the egg collection, which is a minor procedure. Very straightforward. Sometimes it happens without sedation, most of the times with sedation, especially if the number of the follicles is elevated. And then after that, we get the eggs, we give them to the embryologist, and we fertilize the eggs with the sperm, either with ICSI or IVF, and we create embryos, and we leave the embryos to grow. I mean, in our unit, usually we have a 5 days policy. We leave them to grow to blastocyst, which is a day 5 embryo. And then we do an embryo transfer. And the embryo transfer can be either a fresh embryo transfer or a frozen embryo transfer. And when do we freeze? Many times we prefer to freeze all the embryos rather than transfer them on a fresh transfer. Nowadays, with frozen cycles, we have equal or even better chances of success because the implantation window is not affected by the hormones. And freeze all the embryos might be the only possibility when we have severe PCOS, when we have the estrogen levels going quite high, when the progesterone at the time of the egg collection is more than 1.2, in endometriosis cases, or when the endometrium, the lining of the womb, is not thick enough. Now, personalization of stimulation. For all these that have watched previous webinars with me, I'm always targeting on that because it is very important. It is very important to have a very good laboratory, and it is very important to have a personalized protocol. Every single thing during the stimulation plays a role. the preparation for the IVF, what vitamins you take before so that you can prepare, to schedule the treatment. Is it good to take the pill? Is it good to take estrogen priming? Is it better to start on a spontaneous period? This is important. High dose or low dose protocol. It depends on the antral follicular count. It depends on the AMH. It depends on many different things, and it is very important to choose the right protocol. Many times I say that it's the follicles that lead us. We don't usually lead the follicles. We just need to follow the signs of the follicles during the stimulation. And how do we do that? The right way is to do blood tests in every single appointment and accurate follicular monitoring on each ultrasound and to adjust the doses accordingly. Many times we need during a protocol to omit one of the medications, to give half doses, to choose the right trigger. Even this is very important. If you will have agonist trigger, if you will have a combination of a double trigger, if you will have one agonist, 2, 3, even how many days after the trigger you will do the egg collection. It plays a big role in maturity, 35, 36, 37 hours. It depends on how it goes, and then we make the decisions. And we have, of course, many innovative protocols as well in cases that need it, like double stimulation protocols, luteal phase protocols, andro IVF, which increases the testosterone levels for poor responders, many different things. The advantages of using your own eggs, of course, everybody understands these. There is a genetic link to the child. There is the emotional satisfaction of biological parenthood. Many times, though, I mean, especially in older ages, more than 40, the chances are lower. They depend on the age, they depend on the ovarian reserve, and the age significantly impacts the quality and the quantity. How do we prepare for IVF? Baseline tests, Mullerian hormone, it shows how many eggs a woman has. Antral follicular count, it shows the same thing. And you keep in mind that during an IVF cycle, we cannot stimulate more follicles than the follicles that we see in the beginning of the cycle. So if a woman has 10 follicles in the beginning of the cycle, we can get up to 10 eggs in one stimulation. We might get less than that, we will not get more than that. If someone has 20, we might get up to 20. If someone has only 3, we will not be able to get in one stimulation more than 3. Thyroid, very important. TSH ideally needs to be less than 2.5. LH, estradiol, FSH, prolactin, all these hormones show us things that affect the protocol that we will choose. Sperm analysis, ultrasound to rule out fibroids, polyps, and things like that. And of course, we have other tests as well that depend on the medical history. And we might advise, like DNA fragmentation and meiosis for the men, thrombophilia, blood clotting tests for the woman, immunological testing, endometritis testing, microbiome testing, hysteroscopies. All these tests depend on each case and each scenario. The success factors, the main one is the age that we told before. The ovarian response and the number of the eggs retrieved is very important. We have evidence that it shows that in women less than 35 years old, I mean, even 12 eggs might be enough to give you good chances. Between 35 and 37, we might need about 15 to 20 eggs. Between 38 to 40 years old, we might need 20. And in ages more than 40 years old, we might need even more, 20, 30, 40, only to get the one lucky egg. So you understand the difficulty. It doesn't mean, of course, that someone that is 42, if someone gets 2 eggs, might not be lucky and might not have one of them being chromosomically normal and give her a pregnancy. But generally, the rule is, especially in this age group, the more, the better. And you understand that many times in one stimulation, this is not possible in women that have a low ovarian reserve. The embryo quality is very important. We have the grading of the embryologists, and in our unit as well, we have an artificial intelligence system, the Chloe EQ system, which actually predicts the chances of implantation of each of the embryos, increasing the statistics of the right choice of the embryo to put back. And of course, very important, the embryological laboratory expertise, how many cycles, the experience of the embryologist, if time-lapse machines are used, and what we said before, the personalization of the protocol. Uh, for some reason, it doesn't change my slide now. Okay. PGTA is the pre-implantation diagnosis selection, actually. It was used to be called PGS, PGS before, now it's PGTA. And this is taking a biopsy of the embryo, see the chromosomes of the embryo, and put back a euploid, the healthy embryo. PGTA is not for everybody. It's usually for women that are more than 40. It's usually for women that have recurrent implantation failures or recurrent miscarriages. It is important because it can sometimes determine if the problem is the embryo or not, because we don't know why an IVF fails. So by doing the test, at least we rule out if the problem is the embryo or not. It can reduce the chances of miscarriage. It can increase the chances of the first transfer. It does not change, though, the cumulative chances of all the embryos that someone might have. And always we do it when the advantages outweigh the risks, like everything in medicine. So women usually with straightforward histories, less than 37 years old, the advantages might not be more than the disadvantages, so they don't need it. And the results of the PGTA, if you are familiar with that, might come back as euploid, which means chromosomically normal, aneuploid, which means chromosomically abnormal, and sometimes it's a middle category, which is called mosaics. And mosaics, again, are divided into low mosaics, high mosaics, and some of the low mosaics sometimes can give some chances of success if we transfer them after genetic advice. PGT-SR and PGT-M, for those that have heard the words but they don't know what it is, it's techniques again of analysis of the embryos. PGT-M, it's when we have a known disorder. So if someone is, for example, a sickle cell carrier or a thalassemia carrier, and the partner is as well, then these couples have 1 in 4 chances of a baby of having the abnormality. In cases like that, we do PGT-M. But PGT-M, we need to know that the couples have a genetic disorder and check for that. And then PGT-SR are for women that have recurrent miscarriages. Many times when we do a karyotype to these couples, we find out that they have translocations themselves, which might pass in the embryos. And a way of check and reduce the risk of a miscarriage is PGT-SR, which actually checks about these translocations of chromosomes. So what we are doing if the IVF fails? Well, we keep trying many times because one IVF might not give the right number of eggs. The more eggs we collect, the better. And many times we need to keep trying. We might consider PGTA that we've said before. We might consider doing other tests like hysteroscopies, like endometritis tests, implantation windows tests, immunology tests, sperm additional tests, because the sperm is a very important factor. We can try alternative things like acupuncture. It has very good data behind it. We have a very good acupuncturist in Greece who is very good in specifically the fertility. And I don't know if it is working mainly as a stress relief, but we do see sometimes reactions for better results. We have body-mind techniques that can release the stress. We can relieve the stress. We can have lifestyle modifications. We can take vitamins. And if things are very bad, if the quality of the embryos is not good, if chances are very, very low, then we have donor eggs if the egg is the problem, or we even have surrogacy when the endometrium, the lining of the womb, is the problem. IVF is a very stressful procedure. I mean, couples do not have a nice time many times when they go through the procedure. Women, couples need to have support, and they can find the support in friends, they can find it in families, they can find it professional support. Every unit that respects itself offers psychological support as well. Of course, many social groups, social media groups and everything that women can go inside and find other women that have the same problem, and so that they don't feel alone. Books, but there is hope. And there is hope. I mean, it's much better than what it used to be before. The chances are going higher and higher. Technology is going higher. And there are more things coming, like new implantation window tests, AI everywhere in the protocols, in the lab, stem cells, ovarian PRP, mitochondrial treatments. All these are future things that we will see in the future very soon, actually. And any questions you can ask me now. And of course, afterwards, we do offer some free initial chats for any couple that wants to have a consultation with me. And the important things, as we've said before, and what you need to keep is personalization of the protocol, is safety when you go in to have treatment abroad. You need to make sure that the IVF is in a big hospital, that there is an RI computerized system that makes you to feel peace of mind for your embryos. There is a national authority that regulates all the IVF centers. Make sure that you'll have the personalization that we talked before and an exceptional lab as well. And that's our core team. There are more than this, but yeah, that's it.
Brilliant as always. Thank you so much for introducing us to IVF with own eggs and explaining all the aspects that you should know about. But of course, there will be time for your questions. We will go for all other questions. I will show you this. There are a few things here. So let me show you. How many eggs is too risky to have during ovarian stimulation? So it could be a reason to stop the stimulation at all and lose all the potential yield. How common is it to stop ovarian stimulation? Because there are too many eggs, so you just cancel it or don't collect any eggs.
Listen, hyperstimulation was a problem, a big problem some time ago. I mean, to be honest with you, I haven't seen severe hyperstimulation in our unit, at least for more than 3.5 years. And the reason is that nowadays we have vitrification, which is a method of freezing, slow freezing, that does not really compromise the quality of the embryos. So when we are afraid of hyperstimulation, we freeze. We freeze all. And this reduces a lot the chances of hyperstimulation. Actually, in many times, it actually puts them very close to zero. It's not only that, it's also the triggers, okay? We use special triggers when we are suspecting hyperstimulation, and that's why it is important to measure accurately the number of the follicles and to measure the estrogen levels as well. So by using the right trigger and by freezing and not transferring, you minimize the risk of hyperstimulation. And in the units, it should be a zero tolerance to hyperstimulation, because nowadays we do have the measures to prevent it. So we don't cancel a cycle. We are not afraid of increasing the estrogen levels. Many times when we see that the estrogen levels are going very high, we have other ways of not stopping the medication, do what we call coasting or reducing the doses. Many things can happen to prevent and minimize the risk of hyperstimulation. So there are ways of preventing problems so that you don't cancel a cycle nowadays.
Perfect. Thank you so much. That's encouraging. That's encouraging for sure. Thank you. Faith would like to know, I'm 55. In your clinic, do you accept such age, 55, for IVF with donor egg?
I'm afraid in Greece, the upper age limit is 54 currently. So we are not able, unfortunately, to help you in Greece.
54 is the maximum age you can. Yeah. Okay. Thank you for the clarification. How about ICSI? Can ICSI be more harmful or less beneficial than no ICSI in some situations? This is the question from Eve.
That's a difficult question, actually. I mean, if we are talking about risk or problems to a baby that will be born, the answer is what we explained before. Now, if we are talking about the chances of success of having a positive test, nowadays we have reached the opposite stage that because ICSI improves the fertilization rates, we have forgotten about IVF. And sometimes IVF, because it includes the natural selection inside, when we have absolutely fine sperm and we have checked thoroughly the sperm, it doesn't have any hidden reasons inside, like DNA fragmentation, like oxidation, because this is the problem many times that we say, okay, the sperm is okay, but even in normal sperm analysis, it might have hidden reasons inside that if you do IVF, you really lose the fertilization, and this is the problem. But if you check everything and you have a lot of eggs and you have a young woman and you have nice sperm and no DNA fragmentation, many times to split between ICSI and IVF and give a percentage of the natural selection as well, it might be beneficial. As a general rule, though, when the number of the eggs is less or when we have a male factor, mild or severe, of course, ICSI gives advantages in the fertilization rate and also in the conversion rate to day 5 embryos later.
Okay, hope that answers your question as well. Thank you. All right, so now next question. May a heavy cold before the start of stimulation have a negative impact on the quality of the egg? If it's true, how long should a woman wait after the sickness before the actual stimulation?
Okay, listen, difficult again question to answer with clear evidence, to be honest with you. I mean, first of all, what cold? COVID, flu, influenza, B, A, just a simple cold. Just a simple cold with no temperature, with no fever, it shouldn't affect. During the time of the egg collection, which is an invasive procedure, which is a procedure with a sedation, to have a severe influenza infection or a COVID infection might cause issues. We don't know the long-term issues, but no. I have the second question. So just a simple cold, it shouldn't be a problem. I wouldn't delay if we didn't have any fever, if we didn't have anything else, I wouldn't really delay the stimulation for that. It shouldn't affect.
Yeah, that makes sense again. Thank you so much. I hope that helped. I do think so. And we will go back to this one because it's, sorry, I've missed this, but it's okay. Does IVF increase the possibility of more than one baby?
If you put more than one embryos, yes. So that's why it is important to have a consultation with every couple before.
This is another question that is about it. So, can the couple choose to have more than one embryo transferred for twins, triplets?
Well, it depends on the age group, because in every country there are regulations. For example, in Greece, when someone is less than 35 and is having a first transfer, we usually go with one embryo. If it has failed once, we can go up to two. Between 35 and 40, we can go to two. And sometimes when we have failed attempts, we can even go to three. So the law allows it. But the important thing is to have a common decision with your doctor and to have a discussion about what you win with that. So, for example, if you have a top blastocyst of AA, it gives you very good chance. If you put two, the chances of a twin pregnancy might be quite high if you are less than 35 years old. And twin pregnancy is a pregnancy with complications. It can give you hypertension, it can give you preeclampsia, it can give you diabetes, cesarean section. So you balance everything. When you have average quality embryos and you are between 35 and 40, then yes, you might put two, knowing that you have a risk of twin pregnancy and taking the risk of having a twin pregnancy to try to increase the chances. So it is a discussion. It depends on the grading. It depends on your age. And you can transfer up to a specific number of embryos according to the law in every country in a specific age group, of course. Yeah, and with egg donation, for example, you cannot transfer more than two.
Right. I guess that's clear as well. And in regards to the previous question as well, so if IVF doesn't work, would your clinic go straight to ICSI?
ICSI is a variation of IVF. Yes, ICSI actually is IVF. It's in vitro fertilization. It's a technique, as we said, that we take the sperm and we inject it inside. So, I mean, IVF, what I can say about that is that if the fertilization rate by doing IVF is not good, then definitely you need to go to ICSI if you have tried IVF initially. So it depends on how many eggs have been fertilized and what is the fertilization rate, because what ICSI attempts is to increase this fertilization rate.
I think, again, that's very clear. Thank you. Let's have a look at this question. So besides down regulation, already happened 6 months with Raiko. What would you consider doing in the IVF cycle with a woman of 37, 36 with adenomyosis and endometriosis? Recurrent implantation failure is the big problem, and the poor embryo quality, only morula on day 5 or poor blastocyst. Anything you can advise?
So definitely this is not a straightforward IVF. Down regulation in adenomyosis and endometriosis helps, but what we usually say is that it doesn't help if you do it before the stimulation. It is better to do the stimulation, get as many eggs as you can, and then freeze the embryos and down regulate your ovaries before the embryo transfer. Because if you down regulate the ovaries before you do the stimulation, you will decrease as well the number of eggs possibly that you will get. And many times endometriosis is associated with low ovarian reserve. So especially if the ovarian reserve is lower, you will further reduce the chances. So it is important when you will downregulate and for how long. Now it's a very difficult topic. This one, endometriosis has specific things behind it. Many times it is associated with immunological issues, with chronic infection issues. We do specific protocols. We work a lot with endometriosis, and we do specific protocols for endometriosis that might include immunological treatments as well inside, or antibiotic treatments if it is associated with chronic infection. And now the quality of the eggs, it's again a big issue. This depends sometimes on the protocol, but many times when you check very nicely the sperm, when you choose the right sperm selection technique, and the quality in the end is not good again and again and again, it might be a matter of quality of the eggs as well, which is a difficult issue to sort out. In cases like that, the more eggs you get, the more you increase the chances of finding the one lucky one. And if the endometriosis is very severe as well, in rare occasions, you might consider before the embryo transfer to go on a surgery as well or anything like that. But I don't know the story. I'm just saying generally about the endometriosis now.
That's crystal clear again. Thank you so much. And of course, remember that if you wish to get some more details, it's always best to get a direct consultation. And that way you can definitely get more details on your specific case. Next question we have, so should there be a break between these two stimulations? If yes, how long?
Yeah, I mean, usually we advise to leave a period and then you can start again because you are back to the normal hormonically. But of course, you can wait for longer. How long you will wait, it depends on what is your age, what is your ovarian reserve. And keep in mind that many times with poor responders, for example, in women that have poor ovarian reserve, we even apply double stimulation protocols, which means that straight after the egg collection, you do a second egg collection, you do a second stimulation so that you can try to get more eggs in one go. So 2 egg collections in 1 month. So the answer is again personalized. It depends on what is happening. And definitely in most of the cases, you wait for a period to come and you start with the next period, not the one that comes straight after the egg collection as a general rule.
Okay, again, thanks a lot. And now I will show you the next question. What if the woman has a fundal fibroid of 6.4 centimeters, one blocked tube, and another removed from an earlier ectopic pregnancy? Can IVF be the solution?
Well, IVF is the only solution actually, because if one of the tubes has been removed and the other is blocked, you need to go for IVF.
All right. Anything else you can add here?
I mean, if the
regarding the fibroid,
if the question has to do if you need to remove the fibroid, I mean, that's a different topic as well, because when we remove a fibroid and when we don't remove a fibroid, it's very conflicting, many different opinions. Fibroids more than 5 centimeters in size, according to some studies, they can affect the contractility of the womb and can be removed or might need to be removed before even an embryo transfer. But if it is the only fibroid and it is outside the cavity, I mean, in the first attempt, you can do IVF and you can choose to transfer without really removing it. That's what the data says. If I suspect that the question is to remove the fibroid so that you can see if the fibroid blocks the tube, so that you can release the tube and somehow make it work with spontaneous conception. Okay, many times when the tube is already blocked, even if you remove a fibroid, it doesn't mean that it will be properly working afterwards, even if it is patent suddenly. So it depends on the age as well. It depends on other things. I wouldn't really lose time in a situation like that. I would prefer to be proactive because that is what will give you the best chances.
Okay, again, brilliant. Thank you so much. If there's anything else you wish to ask, you know what to do. And now I will show you another question. So what is your opinion on using intra-ovarian injections with exosomes derived from umbilical cord stem cells for poor responders in advanced maternal age? Anything you can advise here?
Listen, we haven't worked with that. It's one of the things that I need, to be honest with you, to look it up a bit more in detail and the evidence that it has behind it. I know the studies. We do not apply it in practice in Greece so far. It was amongst our, thoughts of see if we can make it happen here. But first, we needed to go through all the evidence to see that it works and it has some evidence behind it. To be honest with you, from the things that I have so far read in the data and the research, we don't have any conclusive evidence on how exactly it will help. But it is one of the treatments that has prospects of maybe working in the future. But I cannot really answer because we are not using this technique in Greece. What I can tell you is that we don't have conclusive evidence.
Yeah, still experimental, right? So
Treatments like stem cells from adipose tissue, we have used this and we have applied this, even though, again, for these treatments, you need to know that they are experimental treatments nowadays, okay, and they don't have any conclusive evidence on increasing the chances of success of a pregnancy. But for treatments like ovarian PRP, for example, and stem cells, we have some data, clear data, that it might help in increasing a bit the number of eggs that we can get. We cannot relate it, though, either to improvement in the quality or, clearly the pregnancy rates. And the same thing exists so far for the exosomes as well.
Okay, thank you so much. And actually, next question is regarding how to improve egg quality.
Okay, I mean, egg quality is a big issue. Lifestyle modifications, a healthy diet, specific diets by dietitians that work with fertility. We have in our team one that is very much working and researching about that. There are vitamins that have some evidence. None of these treatments is like miraculous, but the most of the vitamins that have good evidence behind is melatonin, is coenzyme Q10, is vitamin D, is folic acid, and of course we can do like a cocktail of these vitamins to help possibly in the oxidation, reduce and hopefully improving the quality as well. The quality, though, mainly depends on the age and the DNA. So there is no miraculous way of really improving it so far. And then there are treatments like stem cells that have some good, and PRP that have some small data behind it and a trend towards helping in the quality, but we cannot prove it. That's the truth.
Okay, thank you again for the clarification. And next question I will show you. Should one stop taking the pill a few months before stimulation for egg freezing? Can that help get more eggs?
Again, depends. It depends on the situation. I mean, we are dealing here with medical tourism, right? So, I mean, medical tourism, it needs to have scheduling as well. I mean, if someone wants to travel to start a stimulation here and wants to pre-book the tickets, one of the ways is to take the pill so that someone can pre-book the tickets. So you balance everything. And the answer is that if we are talking about a very poor ovarian reserve, maybe it would be better to go on a natural cycle, or maybe it would be better to do estrogen priming and not the pill. If we are talking about a woman that has irregular cycles because of polycystic ovaries, then pill will not affect. Actually, might help with the coordination of the follicles and might reduce the chance of having a big cyst that will make things worse. So the answer is it depends on the case and the doctor's advice, and we usually personalize the cases. I mean, if we take the pill, especially in women with lower ovarian reserve, what we usually advise is to stop the pill at least 6 days before the start of the stimulation. And most of the times, this is enough period of time to recover the ovaries and not lose any eggs, unless we have a very poor ovarian reserve situation.
All right. Again, thank you so much for yet another question and answer. More questions are right here. Okay, I will show you this question, and don't worry, there are no silly questions, but can you explain how do you keep the embryo alive when you freeze them? You mentioned the method vitrification, if you can clarify.
I mean, in the old times, the techniques were difficult. Now it's a technique which is called vitrification, that actually it's a slow freezing technique that does not crystallize the inside of the embryo. And when we thaw it, when we put it out of the freeze, of course, some of the embryos do not survive the freezing. Okay, it's something that always might happen. Most of the times, though, these embryos that do not survive might not be good quality embryos that wouldn't give a pregnancy as well. In most of the cases, though, it doesn't affect at all the quality. And it's actually like putting something in the fridge and, at home and take it out and be the same even if you use it after 2 years or 3 or 4 or 5.
Yep.
In a way.
Thank you so much.
Don't
Thank you so much for the clarification.
Don't put them ever in the fridge, though. Yeah, it's a special.
Definitely. Thank you so much for that as well. And let me just show you. Maybe you can help with. There is some information here. 42 mini IVF Clomid menopause with own eggs, AMH 6.5 picomoles. When I did Clomid alone, I did have 4 follicles at day 11. Good idea. Anything you can advise here?
Okay, it's a protocol. I don't understand exactly the protocol. Most probably it was a combination of Clomid and menopur. We use it many times, especially in women with low ovarian reserve, because you do have poor ovarian reserve with an AMH of 6.5. We go a lot with the size and the number of the follicles as well. So usually, when we have more than 4 follicles, we prefer to go on high doses. When we have less than 4 follicles, there is no reason of doing high doses, because even if we do, we will not get more than 3 eggs, 3 or 4 eggs. And these eggs, you can get them even with lower doses or pills. So to go ahead with a combination of a low dose of menopur and Clomid is a protocol that we use as well in women with poor ovarian reserve with a small number of follicles initially. It works sometimes. We can combine it with a medication which is called Dufaston as well, which prevents ovulating. And it is a protocol that can give good results. There are other protocols as well, and always, one IVF is, like we say, experimental as well, because we find things how you react, and always we get this information and we use it towards our benefit in a second attempt.
All right. Again, brilliant. Thank you so much for the clarification here. If there's anything else you wish to add, you know what to do. We have a few minutes left before we finish. So the next question that I have here is PGTA dangerous? Why not always doing it if it prevents implantation of abnormal embryos?
Yeah. PGTA, it means removing some cells from an embryo. So it is an intrusive procedure to the embryo. In good experienced laboratories, the risk of traumatizing the embryo, of causing injury to the embryo is minimum. But it includes a human factor as well, and sometimes it might cause an injury to an embryo by removing some cells. So you need to balance this risk towards the risk of chromosome abnormalities. The risk of chromosome abnormalities in a woman of 34, 33 are few. In a woman that is 40, 37, 38, 39 are more. So when someone is like 38, 39, 40, the advantages are more than the disadvantages. When someone is less than 35, we don't have this clarity. Also, PGTA, many times, it gives you conflicting results. So it gives you a result that says that it is a euploid normal embryo. Okay, good. It gives you a result that it says it is an aneuploid embryo, which you don't transfer. And it gives you middle category, which is called mosaics. And then some of the mosaics might be transferable after a genetic advice, because they might turn into healthy embryos later on, because the biopsy is not taken from the nuclei of the embryo, it's taken from the outside part of the embryo, so it is not 100%. So by doing that, sometimes you rule out embryos that if you have put back, might have worked. So it's a big situation, a big discussion about PGTA. It's a different topic completely to discuss the benefits and the disadvantages. I'm a big fan of PGTA generally, because it helps you determine what is inside the embryo and rule out what is the reason of failing. But we prefer to do it when someone has recurrent implantation failures, recurrent miscarriages, is close to 40. And for other situations, we do have AI now. I mean, in our unit, we have the Chloe Q system, which actually, without causing trauma to the embryo, can prioritize your embryos. If you have 3, 4 embryos, it can give you statistics and say that this embryo, the way it looks, out of a data that we have collected from many images of embryos, it gives you like 85% chances of implantation, 90%, 60%. So it offers advantages without really causing an injury to the embryo in cases that do not need it.
All right. Again, big discussion on this, so we could do another webinar for sure on that. But thank you so much for explaining that as well. And now we have two questions from the same patient. So first one is, if a 35-and-a-half-year-old woman has an AMH of 0.89, AFC 915 follicles, how many cycles of IVF do you think it would take? And the same patient would like to know how many embryos do you think would be made in one cycle?
Okay, listen, when someone has, Caroline, can you go a bit back to see the number
Sure, yeah.
of the follicles? Sorry. 9 to 15.
9 to 15.
If someone has 9 to 15 follicles, I mean, ideally, in a situation like that, you might be able to get in one go 9 to 15 eggs. It's very difficult to get 15, obviously. It's very difficult to bring them all at the right size at the right time, but you might be able to get like 9 eggs in one go. As I told before, in 35, in order to have good chances of about 70%, the number of eggs that you might get as an average, according to the studies, is about 15. So, of course, this doesn't mean that if you collect 9 eggs, one of them will not be lucky and will not give you a pregnancy. You are in a good age. 35 is a good age. The quality many times is good in situations like that. Many times even 8 eggs might give you a pregnancy. Many times even less than this. So try to get as many eggs as possible. And then the number of embryos that you will create, it's something different. First of all, it depends on the sperm, yeah? And the sperm is a very important factor as well. Second, it depends on the quality of the eggs, which is something that you never know. You suspect that it will be okay in the age of 35, but it depends on genetics. It depends sometimes on hidden endometriosis, on other things. So try to get as many as possible. You might be able to get with this AFC about 8, 9, 10. I don't know if this is the right number with the right protocol. See how many embryos you will have in the end. See the grading of the embryos that you will have. And it depends. If you have like a 4AA blastocyst, it might give you very good chances. Put it back. It might work.
All right. Brilliant. Thank you so much again for that. There are more questions. I think that there are two that we can still take. There are short ones. There are some other very long questions. But let me just show you this one. So one, you need to see it, right? Progesterone during 2 years, 2 times by day can be accepted to increase progesterone levels for the best possible oocyte quality for fertilization at 46. To IUI with excellent quality of young, healthy sperm. Yeah.
I don't see
But,
why someone to take progesterone 1 gram for 2 years. I mean, I wouldn't associate that to the quality of the eggs, first of all. Second, in 46, chances with an IUI are very, very, very low. So I wouldn't really go on this sort of treatment in 46. Even the chances with IVF are very, very low, but might be higher than IUI for sure. And with the progesterone, I don't really understand why for 2 years to take progesterone.
Sure, Natalia, feel free to also send us a message and just explain what you mean exactly. We'll be happy to simply forward this to Dr. Harry, and I'm sure he will be able to take a look at it, okay? We just need more information. Okay, so I will show you this one as well. If a male is having a herpes flare-up during transfer, would you still go ahead with fertilization using a fresh sperm sample? Or do you recommend freezing sperm in this instance?
If the male has got the herpes.
It looks like it, yeah.
At the time of the sperm giving, or when someone gives sperm.
Yeah.
Listen, it can affect the sperm in a way. Yeah. So any infections before, it can affect the sperm. But I mean, if someone has started the stimulation, I mean, I wouldn't stop the stimulation or I wouldn't stop the fertilization of the eggs because of the herpes infection. I would try to treat the herpes infection and still use the sperm. It's not that you will pass something to the embryo, if that's the question. Infections during the time of the sperm giving, yes, can affect the sperm quality. But I wouldn't stop the fertilization of someone that is already in a stimulation because of that.
All right. Let's have a look. Okay, one more thing here. So transferred 6 untested embryos in 3 separate cycles. Would you advise donor eggs at this point? I'm 39 this July. 6 untested embryos, yeah.
I don't know what day of embryos, if it was day 5 embryos. I don't know the gradings of them. They are untested. She's 39. So, to be honest with you, I mean, if you are not, definitely the chances with egg donation will be much better, okay? But if you are not ready to jump to the stage of egg donation, I mean, one of the things that you can do, because I don't know now the full story, is do another attempt and test the embryos, because you need to find out if the problem is the embryos and the chromosomes of the embryos or if something else is happening. So it fails, but why it fails? Is it the endometrium? Is it a chronic infection? Is it the implantation window? Is it immunology? Or it's the problem of the embryos? So first, check the embryos if you want to keep trying to find out if you can achieve a chromosomically normal embryo or not. And if you manage to achieve a chromosomically normal embryo, then you need to investigate everything before you put it back, because obviously you're struggling to achieve this embryo, and this will be a very precious embryo. Now, I need to know the whole story to tell you what are your chances, to know the gradings and other things, your AMH. So I cannot really go through all this now, but by any means, you can book a chat if you want. We can discuss it.
The patient added day 5 good to medium quality embryos, yeah?
So she did achieve day 5 embryos, 6 also. So it's not that she doesn't achieve day 5 embryos. Good gradings might be something else which is causing the problem. I mean, if it is something else, even if you go to egg donation, it might fail again if it is not the embryo the problem. So try it again and to see what is the problem, and let's take it from there.
Sure. Thank you so much. And now I will show you the final question for today. There are more, but of course, remember that if you have more questions, you can either contact me. I have just sent my email address in the chat, or you can simply directly contact Dr. Harry, and we'll be also able to simply forward this to him as well. And this is a question from Eve. Some clinics still freeze embryos on day 3. Is it old school, old protocols?
Yeah, well, it can happen. And there are clinics that do it. To be honest with you, in a laboratory that respects itself, I don't see any way of not leaving the embryos to day 5, unless you are afraid of be left without an embryo and not do an embryo transfer. But this is not the point. The point is to get you pregnant. So a day 5 embryo has gone through the natural selection of going from day 3 to day 5. So in a laboratory that is a quality laboratory, the embryos that do not reach day 5 are embryos that even if you have transferred them on day 3, they wouldn't have given you a pregnancy. So I don't see a reason of doing a day 3 freezing. At least we don't have this policy in our laboratory, because we respect the laboratory, and the embryos that will be left in the end will be the embryos that will give you better chances.
Of course. Brilliant. Thank you so much. That was a very interesting and lots of questions session. Sorry. So thank you so much, Dr. Harry. You can see thank yous are coming up your way. Definitely. Thank you so much. That was really helpful. I'm impressed with how much information I got today. So thank you so much. Thank you everyone for joining. I'm really happy to see your comments and know that it was useful for you. Dr. Harry, anything you would like to add, as always, before we finish for today?
Nothing. It was nice to be with you, and I'm glad if I helped. Anything that you need, you can find us online.
Definitely. Of course, remember, we'll be happy to forward any of your questions. You can get in touch with Dr. Harry directly. And I will just tell you that, of course, it has been recorded. You will have a chance to watch this again. It will be available on YouTube channel tomorrow, and on our website, myivfenses.com. You can go there, and there are plenty of previous webinars with Dr. Harry as well. But of course, remember, we will be back with some more events. So join us. We will be back next week. And there are plenty of topics that we will discuss this year, so stay tuned. Dr. Harry, as always, thank you so much. Have a lovely evening, everyone. And of course, we will see each other quite soon, I know as well. Thanks. Take care. Bye.
Bye.